It's good afternoon. Um, okay. All right. So this is on 1.5 speed because we're really doing time management by this point. So the initial title of my talk was supposed to be State of Thrombectomy in the Philippines, but as I was going through the literature, I decided to revise the title to Stroke Care because the data really involves all the stakeholders for stroke care, including the neurologist, the neurointerventionist, the rehab specialist. So special thanks to my teammates for helping me with this presentation. So I have no disclosures, but the disclaimer is I am just a messenger for the data. So everything here are solicited information from my mentors and all the practicing neurologists from various institutions. So initially, this presentation involves some interesting cases, but we removed them because we were considering the time. So this will be the outline. I'll do a short introduction, present the Philippine healthcare situation, and I figured that we both have a lot of, Pakistan and the Philippines might have a lot of similarities in terms of the public health considerations for stroke care. So, short show of hands, who of you have been to the Philippines? I guess none, right? Oh, just one. Thank you, sir. So, you're here, the red dot in the Philippines is here. It's a short 13 to 14-hour flight, no direct flight from Pakistan. And it is an archipelago of over 7,100 islands. It depends on whether it's low tide or high tide. It can go up to 7,600 islands. But it's composed mainly of 3 island groups: Luzon, which is the northmost, the cluster at the middle is Visayas, and the cluster at the southernmost part is Mindanao. And each of these island clusters have at least one or two capitals. So in Luzon, we have Manila over here. In Visayas, Cebu is over here somewhere, and Davao is here. So the Philippines has a population of 118 million, land areas around 300 square kilometers, and half of the population actually occupy the cities. For the longest time now, it has been documented that stroke is the #2 killer in my country. Second to ischemic heart disease. Third is cancer. And it has been consistent in the top 5 leading cause of disability. But due to our geographic challenges, the geographic setup, we don't have a lot of information in the small islands. The true stroke prevalence is really unknown. So we do have a lot of groups, and there's a multidisciplinary initiative that wants to improve stroke care in the Philippines, and evaluating the current state of stroke care, the needed resources, and the gaps in health policies and programs is crucial to decrease stroke-related mortality and morbidity effectively. As of now, it is quite unfortunate that the mechanical thrombectomy rate is still at around less than 1%. It's because of all the issues of cost and access. Fortunately for us, we do have support from the government. There is an established legislation that defines the national policy and framework for the prevention, control, and management of acute stroke. And it is enacted by our health ministry. So with all the collaborative efforts of the neurologists, neurointerventionists, and all the stakeholders of stroke, these were the identified gaps in stroke systems of care. This was taken from a journal article created by a really energetic neurologist in Frontiers for Neurology. So we have low government insurance coverage with high out-of-pocket expenses, low numbers of health practitioners, lack of imaging, lack of dedicated stroke centers. We have variable stroke protocols because of the geography and access to resource, lack of infrastructure, inadequate acute stroke-ready hospital units and rehab facilities, and one of the more important ones, it's poor community stroke awareness. It's actually quite good that I follow Dr. Sakur's presentation because I have a lot of ideas from what you guys are doing. So let's start off with the most important one, which is resource. We do have a national insurance system, but it doesn't really help a lot. For ischemic stroke, the coverage is just about like 500 USD. For hemorrhagic, it's around 700 USD. And more than 70% of expenses are out of pocket for these patients. Considering devices, PFs, hospital costs, the estimate for mechanical thrombectomy back home per procedure is around $18,000. Now take that and to put you into perspective, a normal Filipino on minimum salary earns $5 to $11 a day. So the stroke burden in the country is quite heavy because all of these resource limitations are present. So we also have identified that there's a limited number of healthcare professionals when we're far from the ideal number. As of 2021, there is one neurologist for every 218,000 Filipinos versus the recommended ratio of 106 neurologists per 100 population. And the Philippine Neurologic Association members decided not to be members of the private insurance firms because the insurance companies pay really bad, like really low PFs for them. So they decided as a group to be not affiliated with the insurance companies. For the interventionist, so right now, the total IR in the Philippines are just 77 for 118 million. Only 59 are in active practice. So if you compute that, you have one interventionist for every 2 million population. And for those neurointerventionists who have specialized training abroad, because we don't have any dedicated training yet, there's only 8 neurosurgeons with endovascular training plus 59 IRs in active practice. I am an interventional radiologist with specific interest in neurointervention because I come from the Philippine General Hospital and we get all the service and charity patients, so we're kind of neuro-heavy. But this is still, majority of us still has the scope of practice. We do mixed type. So I still do peripheral interventions. Everybody does the mixed type of practice. We go into the head, we go into the body, the hands and peripheral intervention. So unfortunately, we only have 10% of the practicing IRs who have gone to other places, came back, because a lot of those who are coming out are not coming back because of better opportunities. I think it's similar setup here, right? Yeah. We have been having this exodus of healthcare professionals constantly, and in my practice, it's fairly normal to have the rehab specialists, the PT, the nurses to leave for placements abroad every 2 or 3 years. So the continuity of care and improving the quality of care kinda is a struggle sometimes. And then in terms of imaging facilities and cath labs, we have 62 cath labs, and most of them are actually in the centers. So Manila has 25 cath labs. Manila has 25 million population, 25 to 30 million depending on the time of year. And for the imaging modality, we have 1 CT machine for every million population, 0.3 per million population of MRI. So, and the thing here is there's public and private institutions, and people tend to flock to the public institutions more because it's more affordable, and for some population, it can be free. Okay, now we move on to the management. So, fortunately for us, the legislation passed placed a good foundation for the coverage of PPA. Before 2016, it was kind of low, 1.4, but it's gradually increasing by the year, and our neurologists are constantly doing studies on this. They pinpointed that stroke training, education, and increasing public awareness really increases the statistics for these things. Okay, so the higher thrombolysis rates in the public hospitals consistently are seen because of the subsidy of the government. So we have a system. The Philippine Stroke Society has a system wherein they assess institutions who want to be stroke ready. They have a criteria for the standard of care. And as of now, we have 49 stroke ready hospitals out of 119 level 3 hospitals and 353 level hospitals. So we pretty much have a long way to go in terms of preparing the hospitals to be stroke ready. But we are getting there. And the geography, as you've seen the map, the geography of the Philippines present a very difficult challenge in terms of transporting patients. So we do get patients who take helicopters, boats, car, motorcycles, and some even walk to the hospital. So the data says that a lot of these patients get the proper management at a very late time. And only a small population gets IVT, EVT. So, in terms of mechanical thrombectomy, according to this journal by Chang and et al., the Philippines actually is included in one of the countries with really high stroke burden, but very, very limited EVT and IVT. It is because of these factors. I'm sure you're also familiar with it. And I do have to admit we're still beginning to do the documentation because a lot of the cases are done by our seniors. And one of our young ones, Dr. Hoxon, just did a study, published it in one of the peer-reviewed journals. But it was a low sample population, but this is one of the papers he published. Unfortunately, our older bosses have logistical challenges when it comes to research, so we have to work on that too. So, 2 more minutes. Okay, so this is a spoke wheel as well, identifying the different steps that are needed to improve stroke care in the Philippines. And I'm sharing this because, as previously mentioned in the past days, it's good that we work together, share our best practices so we can learn from each other. Also, the journal where I got these data from are available online in PubMed. So looking into the future, the initiatives right now is, I think the Ministry of Health is starting to realize the high burden of stroke and the possibilities of significantly reducing it. So right now, there is a law that places inclusions of cath labs in the big centers. So the goal is to have 1 cath lab in each of the 73 provinces. The PSVIR, that's my society, we're establishing linkages so we can train further and having partnerships so we can grow the numbers of qualified and trained interventionists that do procedures. So this is a slide from the website. I got the posters from the website of the Stroke Society of the Philippines. I'd like to talk to you guys about this because we've been talking about multidisciplinary collaborations and working together because, stroke care starts just when the person comes in your ER or is reported up until he gets better. That includes giving meds, doing thrombectomy, doing the rehab, taking care of the patient and the family. So these are the efforts by the Stroke Society of the Philippines. And the nice thing about the SSP is that the members are all advocates of stroke care. They do not discriminate if they're doctors, if they're nurses, or whatever. So they have community workers, they have neurologists, pediatricians, even OBGYNs, and rehab medicine specialists that are part of this society, and they actually take turns to do sharing of their knowledge. So they have constant webinars and they take turns. So the neuro first and then the rehab. They even had a session with a psychiatrist that addresses the patient as well as the caregivers. So Sorry. Okay, so this is just a poster of our last convention. We included we always include neurointervention in the topics that we uh, include in the program, and of course, initiatives include prodding the young ones to go on further training, establishing collaborations with various partners across the globe. And sorry for if I'm not able to include a lot of the logos. So. Oh, okay. So in conclusion, so the status of thrombectomy in the Philippines and stroke care in the Philippines is evolving. We do have a long way to go, but I think it's important that we have identified the gaps already, so we know how to approach it. And I really appreciate all the lectures that I've listened to because we're learning a lot here. And it's important to do the systems approach because we have to consider and improve all factors to address the gaps to optimize progress and development. I'm not gonna end my presentation without the proper acknowledgements for the people who helped me. And thank you for your attention. These are the top 6 favorite spots in the Philippines, my personal favorite spots. Thank you for your attention, and I hope I was on time, right? Okay, thank you.
Thank you very much. Thank you. Yes.